want to thank you for this opportunity to present to you. As you just heard, my name is Rob Bartha. I'm the chair of the board for the Alzheimer Society of London-Middlesex. And presenting with me this morning is Cathy Ritsema, the executive director of the Alzheimer Society of Huron County. We represent the Alzheimer Societies for the South West region. So there are 6 regions or counties represented. There's the Grey Bruce, Huron, Perth, Oxford, London-Middlesex, and Elgin-St. Thomas. I want to point out that we are also members of the community support sector in the Southwest region. So why are we here today? So primarily, we are here to inform you about Alzheimer's disease and other dementias, and most importantly, to inform you about the services that we provide.
We also want to demonstrate to the LHIN that an investment in dementia care will alleviate pressures on ALCs, long-term care beds, and emergency room visits. We, the 6 chapters, are part of the community support services sector in the South West LHIN. We are a member on the Community Support and Development Council, where we work together with other community support services in the South West LHIN to deliver services that are client-centered, effective, and efficient.
The next slide gives an overview of our collective mission, vision, and values, which align with the mission, vision, and values of Alzheimer's Canada. So very briefly, our mission statement: to alleviate the personal and social consequences of Alzheimer's disease and other dementias, and to promote research. Our vision is a world without Alzheimer's disease, and our core values include collaboration, a client-centered focus, accountability, respect for human dignity, and excellence. So what is dementia? Dementia is a brain disorder that's characterized by impaired cognitive functioning that can affect learning and memory, as well as mood and behavior. It's a degenerative brain illness, and it includes things such as Alzheimer's disease, vascular dementia, frontotemporal lobe dementia, and Lewy body disease. All of these lead to irreversible forms of dementia that are progressive, start slowly, and are progressive, and shorten life expectancy. The median time of survival of Alzheimer's disease, which accounts for about 60 to 70% of dementia cases, is estimated at about 7 years. And currently, in Canada, there are about 750,000 Canadians that are living with dementia. And this is expected to double to about 1.4 million by 2031. As the baby boomer population ages, the number of seniors with dementia is expected to increase dramatically. In Ontario, nearly 200,000 people over the age of 65, or 1 in 10, are now living with dementia, an increase of 16% over the past 4 years. By 2020, close to 250,000 seniors in Ontario will be living with dementia. And if we look at the numbers in our own region, currently there are about 16,000 people over the age of 65 that are living with dementia. And this number, as you can see from the graphs, is expected to increase substantially over the next 5 to 10 years. So what do we do best? At the Alzheimer Society, our primary objective is to be the first contact, the first link for people with dementia, for their care and their caregivers and families. Our First Link program connects individuals with Alzheimer's disease and other dementias and their families to a community of learning, services, and support throughout the continuum of the disease.
So the goals of the First Link program. In the beginning, several years ago, the Southwest was a pilot project for the provincial First Link program, and that was so successful that we were able to roll it out throughout the whole Southwest LHIN. So we want to increase the effective and efficient utilization of community resources. We want to strengthen the linkages between diagnosing physicians and all healthcare professionals in the Alzheimer Society and the community service providers. We want to reduce the overall incidence and intensity of crisis situations that tend to happen when you are caring for somebody with a dementia, and the reduction of caregiver burden by providing early access to learning services and support. And that's what First Link does so beautifully. It also gives us a standardization of care throughout the Southwest LHIN. We all provide the same service, and we have a standard that we go by. So wherever you are in the South West LHIN, whether you're up in Tobermory or down in St. Thomas, you will get the same service through the First Link program. So what First Link does is it provides support service throughout the continuum of the disease process. So we go from pre-diagnosis right to the end of life. And quite often, we do get phone calls from several people who are concerned about their memory. And even from that beginning is when we start the foundation of care. We really encourage people to start right away. Although, in the First Link program, that anywhere they are on the dementia journey, they can join the program. So First Link has three main components that we work with. First of all, intake, where we have direct referrals, increased early access to services for clients, and saves time and energy on the healthcare providers. There's the assessment. So either in our office or in people's homes, we do assessments to determine the individual care needs, and we work with the person with the disease as well as the caregiver. And then and we also work with other healthcare professionals who are involved to develop an individualized care plan for each person. And then we offer the counseling and support services through our registered health professionals at our offices as well. So the First Link's Learning Series provides vital information to caregivers and individuals who are experiencing either Alzheimer's disease or another dementia. The first steps is for persons with the disease. So what we want to do is we want to be able to empower and equip people who have the disease to develop their own care plans, to do self-management, to be able to manage the disease well. And we do that first of all through education. So what they'll learn in the First Steps program will be the different types of dementia, what's happening in the brain. We work with them to develop coping strategies that gives them hope and confidence that they can continue on, and we help them plan for the future. So as I said earlier, that they can actually self-direct their care. And it's a forum for people with the disease to come together with other people who have the disease and to feel normal, that they're not doing, that they, what they're feeling is similar to what somebody else is feeling. They develop friendships and they develop a support on their own. Because at this stage in the game, most of our clients would not qualify for any other services, the other support services or CCAC. So this is where they can develop those, that support. Yeah, I think I missed a page. And then the next steps are for family members and friends who are caring for people with the disease. And again, we'll go through the different types of dementia and what's happening in the brain to educate, because we believe too that education takes away a lot of myths and a lot of fear so that people can cope better. And they too, when they come to support groups, they are involved with a family of care people, caregivers who are going through the same thing, and then they too can support each other. And this also reduces the caregiver burnout. And then the other two learning series are Care Essentials, which go through communication strategies, because as the person progresses with the disease, the communication often is impaired, and activities of daily living. Again, we want to give them coping strategies and give them techniques that they can have so they can have a more independent life. And we help them to work through how they manage behaviors, because we know that all behavior has meaning. And then we want to make sure that they are safe and secure in their home environment, caring for themselves too. And then options for care is where to turn to when the care needs are increasing, how the long-term care system works, coping with the change, because there is a lot of change that comes along with it. And again, we want to always meet the family where they're at. And the very last one is Care Essentials. Okay, I did that one. Okay. So additional support services that we offer, many of us have drop-in caregiver support groups. We have monthly groups set for people with the disease and other dementias. And we recently, last year, were funded through the Behavioural Support in Ontario, where we were each given a 0.5 FTE to social worker to help with the behavioural responses. And we also work with the, through OTN and other accessibility technologies. Many of us are involved with our local family health teams where we do memory screening clinics. So we're part of that team that meets the person in the very early stages. And as they go through, then we can offer services, help them to find the right services that they are needing at the time. And we also offer many social recreation programs. And all our programs are free. We don't offer us any client fee. So one of the programs that several of the chapters do is a volunteer companion program, where we train volunteers, and they actually go into the homes and work with the person with the disease, and it gives the caregiver some respite.
We also offer a number of other social recreation programs that are not funded by the South West LHIN. And this slide lists several of those programs. I'm just going to highlight a couple of them. So the Food for Thought program is a monthly program where clients and volunteers cook a delicious meal which they enjoy together. And this program is available to people who are in the early stages of Alzheimer's disease or other dementias. There's the Generation Link program, which is a program where individuals with early stage Alzheimer's disease or related dementia, along with either a high school or university student, student teachers and retired teachers, work together to create a memory book that reflects the life experiences of the person. The Garden Club is a monthly nature-based program for those in the early stages of disease. Together, clients and volunteers create interesting projects in a fun and relaxing environment. And finally, we have the iPods for Memories program and the Intergenerational Choir programs. So iPods for Memories is a pilot program that involves one long-term care center and one retirement home. This is a program where iPods are individualized, so we put songs on them that mean something to the person with dementia, which helps to de-escalate behavioral problems that are associated with the dementia. And the Intergenerational Choir project is a program where individuals and people with dementia join with high school students to sing and socialize and interact within a structured program. So the iPod for Memory program and the Intergenerational Choir program demonstrate the power of music in helping people that are suffering with dementia.
Another one of our programs is our educational programs that we provide for healthcare professionals, where we go in and work with healthcare professionals in long-term care settings. We provide Montessori-based dementia programming. So what we believe is all behavior has meaning. And we want to be able to equip the staff in long-term care to be able to work with their residents so that, first of all, the resident is having quality of life. But second of all, as well, we want to make sure that we support the staff so that they're able, that they have the tools and the techniques that they can work with the people with the disease. So these are some of the programs that we offer. Gentle persuasive approach in dementia care, again, is another client-centered approach to care. Aging stimulation workshops. You First is for non-registered staff, PSWs. The PIECES program is for registered staff. So we will go in and work with all the staff. I just wanted to give one example before I go on. When we'll often get calls from long-term care facilities about behaviors and how difficult it is to handle people. And as I said earlier, we believe that all behavior has meaning. And there was one gentleman who was refusing to have a shower. And as soon as the staff would take him to the shower, he would get quite aggressive and act out. And what we work with the staff, and we want to find out as much about the person as possible. So we found out that he came from Jewish descent, and he was in a concentration camp back in World War II. So going to that shower was a reminder of what was happening at that time, and that's why he had such a, that's why he was acting out. So that's why it's so important for us to go in and help the staff and train them so that they treat the people, so that they know what the person's going through. So that's one of the, that's just a story that I remember that really impacted me. So we also have a range of public education opportunities that, that we give, and we go from young to old. Because we also know that from some of the research that as you age also determines whether you can, whether you may develop Alzheimer's disease or not. So we work with students in the grade 4 range right up through to Johnny for seniors. We go to all the service clubs. Anybody who will listen to us, we'll actually go and talk to. So that there's no age barrier there. And a few years ago, we decided to change our focus, that we just didn't want to talk about the disease, but that we really want to talk about healthy living, so healthy lifestyles. Because research has told us as well, we know now that through exercise, good diet, brain exercise, physical exercise, it will all help to reduce our risk of getting Alzheimer's disease or another dementia.
We're also interested in creating more culturally diverse programs. And we have some examples of this already. So we do have some existing bilingual services at some societies. And one example of a successful program was the program that we had with the Oneida Nation on the Thames. So the Oneida Nation on the Thames was a program that was designed to support First Nations people affected by Alzheimer's disease and other dementias. The program included individual and family support counseling, bereavement support, memory screening, dementia awareness, and advocacy. This program was not funded by the LHIN, but was funded by a Trillium grant, and unfortunately that grant has run out now, so the program is no longer functioning, but it's an example of the kind of program that we would like to run more of. So that gives you some idea of what we do, and now we'd like to get into some numbers. And what I have here on the slide is a summary of the number of people that we have been helping over the past year. So this is how we know we're having an impact. So on this slide is a summary of, first of all, in the first column, the number of people with dementia that we have helped in our region. So in total, through the 6 societies, we've helped just over 900 people with dementia. In addition to that, just over 1,750 caregivers. And that gives us a caregiver to patient ratio of about 1.9. In some cases, we have client to support staff ratios that are greater than 200 to 1. How do we know that we're having an impact? Well, provincially, the Alzheimer Society took in over 5,700 people with dementia in 2011-2012, and over 16,000 caregivers. This gives a caregiver-patient ratio of about 2.8. High-need seniors receive at most a few hours more of home care per week than those with moderate needs. This is a direct quote coming out of the Dementia Evidence Brief from the Alzheimer Society. In some cases, seniors with high needs actually receive less care. The additional care is contributed by family and friends. Now, evidence shows that people caring for someone with dementia provide 75% more care hours than caregivers that are not providing services for people without, or that are providing services for people without dementia. These people also report feelings of distress, anger or depression, or inability to continue care in 1 out of 5 cases. A recent Canadian Institute for Health Information study determined that the rate of caregiver distress was 5 times greater among individuals who are caring for seniors with moderate to severe cognitive impairment, likely resulting from Alzheimer's disease or other forms of dementia. And this is compared to individuals who are caring for seniors without cognitive impairment. The point that we're making here is that caring for the caregiver is very important. Providing services targeted to caregivers as well as to the person with dementia is important, as the outcomes impact positively on the cost of healthcare. The other way that we know that we're having an impact is through client satisfaction surveys. So here are the results of a survey from 2012 from the South West Region Client Satisfaction Survey, which showed that 93% showed a 93% satisfaction rate for caregiver support and almost a 94% satisfaction rate for health promotion and education. These represent our commitment to quality improvement and demonstrate that we are continuously striving for excellence and efficacy.
And here we have a quote from Elaine and Alvin Stewart from Owen Sound. "I am so appreciative that we can talk to each other, and that has helped me realize that I'm not the only one."
And from Jeff and Glenda Shaletto from London, "The Society feels like a safe haven in the middle of a tumultuous storm. We have access to professionals who not only understand this horrendous disease, but who support us, educate us, and advocate for us. They genuinely care."
We're going to show a quick video clip right now of Jan, and if you'll notice, Jan is the one in the striped sweat who has the disease, and she's early stage.
Jan participates in these programs over there, Food for Thought and the Garden Club. And whenever I go and pick her up after one of those, she's just on cloud nine. She's had such a good time. And I asked her once, why? And she said, because when I'm in there with those people, I forget I have Alzheimer's. I feel like just a normal person. And they're very special that way.
So how do we know we're having an impact? The number of registered clients that receive services from the Southwest Regional Alzheimer Societies in 2011 and 2012 are shown here. 2010-2011 numbers were 3,190. That increased to in 2011-2012, that increased to 3,500. That represents an increase of 11%. And this increase is greater than that predicted by the Rising Tide report of 2010. So what is the prevalence of Alzheimer's disease in our region? So this information is taken from the Hopkins report. It shows data for 2012 and then projections for 2016 and 2020. And these are numbers throughout our region. So we'll focus on the totals at the bottom. In 2012, we had approximately 16,000 people in our region with Alzheimer's disease or related dementia. In 2016, that number is expected to increase to 17,500, and in 2020, a further increase to 19,600. That represents an 11% increase from 2012 to 2016, and a further 11.5% increase from 2016 to 2020. How much does this cost? So this slide is just a little bit of data that summarizes programs that are supported by the LHIN currently. So what we have here is a bar graph that shows for LHIN supported programs the revenue that we've received from the LHIN as well as the actual expense of the program. So the blue bars are the LHIN revenue, the red bars are the actual expense of the program. So in total for 2011-2012 we received just over $2.5 million from the LHIN. The program expenses actually exceeded $3 million. So this is a difference of $500,000 that we had to raise ourselves in order to support these LHIN programs. We also have other programs that we support on our own. But one point that we'd like to make is that dementia is the key diagnosis related to hospitalizations with alternative level of care days. So this is also a direct quote from the Dementia Evidence Brief from the Alzheimer Society of Ontario that was put out in July 2012. The term alternate level of care describes the use of hospital beds by patients who no longer require acute care services and are waiting to transfer to more appropriate settings such as residential care or rehabilitation. The Canadian Institute for Health Information has determined that 1 out of 4 Canadian seniors hospitalized with alternative level of care days in 2009 and 2010 had a diagnosis of dementia. That's 1 out of 4. Moreover, hospital stays involving clients with dementia were twice as long on average. The median was 20 days versus 9 days compared to seniors that don't have this disease. In a recent study, the Institute for Clinical Evaluative Sciences indicated that in 2008, the South West LHIN had 503 alternate level of care hospitalizations involving community-dwelling older adults with dementia. Without improved dementia care, the number of ALC hospitalizations involving seniors with dementia is expected to grow in proportion to the increase in dementia prevalence. By 2016, the total number of ALC hospitalizations involving seniors with dementia in our region could surpass 630 per year. Acute care hospital bed gridlock will continue until dementia is recognized as a central part of the ALC crisis, and effective strategies focusing on dementia are put into practice. So how do we fit with South West Regional LHIN's integrated health service plans? So the Alzheimer Society's First Link programs align with the 4 IHSP strategic directions. First of all, we improve access to family health care. Secondly, we improve coordination and transitions of care for those most dependent on health services. Third, we drive safety through evidence-based practice. And fourth, we increase the value of our health system for the people that we serve. These 4 points align with the Senior Strategy Report, Living Longer and Living Well. They align with the Drummond Report, the Action Plan for Healthcare, and the Excellent Care for All Act. And I'm sure you are all familiar with those reports. We are here today to speak to the fact that dementia care in our LHIN is not receiving adequate funding to meet the current needs of our clients and the ongoing dramatic increase of those that are requiring our services. We noticed that the Senior Strategy Update is an item on your agenda today, item 6.4. You will also see that the First Link Alzheimer Society program is listed under key areas of focus for implementation. I'd like to read a quote now from the Alzheimer Society of Ontario Dementia Evidence Brief from the South West Regional LHIN from July 2012, which was prepared by Dr. Cathy and Dr. Mullner. So I quote, "As part of the mandate of the Integrated Health Service Plans, is to consider major trends and respond at a local level. We are urging the local LHINs to adopt an integrated care strategy that encompasses major chronic conditions and acknowledges the confounding cumulative impact of dementia by making improved dementia care a central component of the next IHSP."
So what's our future focus? Recently, we've engaged Jim Whaley to work with us to develop an alliance or an agreement between the 6 chapters in the South West LHIN. So we envision collaboration among the 6 societies to yield shared communication expertise, formation of a quality care committee, accreditation readiness, and standardized policies and definitions of acceptable caseloads and waitlists. The leaders group will determine on an annual basis which collaborative projects will be developed and implemented through our work group, with action plans developed and approved for each project that include deliverables, timeframes, and required resources. So what are our guiding principles? First of all, it will be client-centered. Services must be client-centered, meaning right service for the right place at the right time. And we work together cross-border, that no boundaries, so that all clients are served. We will be accountable. The 6 societies will be accountable to each other through regular and proactive communication and information sharing and follow-up to group commitments. And we will be collaborative. We are building on a history of collaboration among ourselves already, and we're just going to make this stronger. We will be consultative. Excuse me. The 6 society boards, staff members, and the South West LHIN will be regularly consulted in the design and implementation of our collaborative strategies initiated as a result of this new agreement. And continuous quality improvement. Members are committed to improving quality through ongoing process improvement, evaluation, and of course our client experience. Our future goals: we will be facilitating joint staff training and staff expertise within the 6 chapters, where staffing can be shared amongst the chapters possibly. Design and implement standardized service strategies to improve client access, client experience, and our client outcomes. Evaluate and pursue strategies to better coordinate administrative functions improving efficiencies and cost effectiveness, and we want to build capacity within the 6 societies.
So, this brings us to the end of our presentation. Just to summarize what we've said, the numbers of people with dementia are increasing continuously within our LHIN, within the province, and within the country. The Alzheimer Society is the first point of contact through the First Link program for the majority of people with Alzheimer's disease and other dementias. The cost of dementia care is very high and continues to increase. And the reality is that we are only serving a very small fraction of the people in our LHIN who require our service. So what do we need? Immediately, we need to meet the needs of our rapidly increasing client base and increasing program expenses for 2013-2014. We need to expand our First Link program and to address the high client-staff ratio. We need to be funded according to the population and clients that each society serves. And finally, we need to receive financial support for ongoing collaboration, standardization, and integration. So that brings us to the end. I want to again, on behalf of the Alzheimer Societies from within the LHIN, sincerely thank you for this opportunity to present to you today. And I know that I and all of us here would be more than happy to take any questions that you have.